Could I get a sound check, please?
We hear you loud and clear.
Thank you.
Good afternoon. The hour of 2 o'clock having arrived, it is time to call our committee meeting to order. This is the Health and Hospital Committee for Santa Clara County. First item of business is to call the roll and establish the presence of a quorum so we can formally call the meeting to order.
Vice Chairperson Lee.
Good afternoon, President.
Chairperson Zimidian.
Here, we have a quorum. Thank you very much. That takes us to item number 2, public comment. That's the portion of our agenda set aside for comment by members of the public on non-agendized items properly within the jurisdiction of this committee. Do we have any speakers, Madam Clerk? We have 2, and we'll ask them to come forward if they are present here in the chambers, which I gather they are.
Apologies, I have 1 in the room, 2 online.
1 in the room and 2 online. We allow up to 3 minutes. Let's ask our first speaker here in the room, and then once we get to the end of that speaker, we will close the queue for those who are online, okay? Who do we have here in the room?
Cami Van Kuren.
All right, please come forward.
Good afternoon, everybody. My name is Cami Van Kuren. I'm with Valley Health Foundation, and I am just here to cordially invite all of you committee members, as well as the Board of Supervisors and everyone here on the call and in the meeting, to our annual Bloom Energy and Toronto Wireless 5K, 10K walk run on June 29th at Discovery Meadow. It is a benefit of the Valley Health Foundation, which helps support our health system. So we're very excited about this event coming up and want to make sure that everyone has been invited and notified. It is a very family-friendly event. There will be a helicopter landing. We have engaging booths in the festival area, a beer mimosa garden if it is so your choice with games. So please come and join us on June 29th, and you can register at starsandstridesrun.com. Thank you so much.
Thank you very much. And just to be clear, for those who prefer to donate but not walk or run, that is permitted, yes? Yes. Yes. All right. Thank you very much. Next speaker, who is online?
We're holding at 2 speakers. Our first speaker online is Ben Z. You'll have 3 minutes to speak.
Go
The timer
right
will
ahead.
start when you begin
Thank
speaking.
you.
Yes, hello, good afternoon. I addressed this committee the last time it met because my kids, they're being sexually abused. I mean, one of them has already confirmed it, and I can't get a screening to start the process of getting them protected. And that's because there's a conflict of interest in this case. And with the county and a private attorney and a retired judge. And I asked you guys, can you guys please help me get a screening? And nobody's done anything to help me. I'm beginning to think this is not Santa Clara County. This is the county of Kandahar, where this kind of thing, it's allowed to happen. And I don't understand why. What right does a retired judge and a private attorney have to do this to my kids, to force them to live like this? And what right do you guys have to look away? I don't understand. I mean, you guys here are, right this moment, you guys are collecting a paycheck from the taxpayer or funded by the taxpayer. And you guys are looking away, and this is happening. This is not just my kids. This is happening to other children in this county. Speak with Violet Brooks. Her children were forced. They were forced to undergo this sexual abuse. And these 3 young girls could only take legal action, after they turned 18. I mean, it's just terrible. I can give you guys more names if you guys want more names of more children who are forced to live like this because a private attorney wants to keep collecting paychecks. Now, I'm going to ask you guys again. My name is Ben Z. Supervisor Lee, he has all my contact info. I'm sure he'd be happy to provide it to you. If there's somebody here who can help me get an emergency screening for my children to get them protected, please talk with Supervisor Lee, and hopefully something can be done. Because you guys are mandated actors, not mandated reporters, mandated actors. Please help me. Thank you for your time.
Thank you. And our third and final speaker is?
Andrea Wald.
And before that speaker begins, let me ask Ms. Christian from my office to approach the dais, please. Go right ahead, speaker number 3.
Andrea, we've opened your microphone. You'll have 3 minutes to speak.
Thank you. Thank you for the opportunity to address you all this afternoon. My name is Andrea Wald. I'm a member of Community for Natural Place Surfaces. I'll make this comment very brief, as I've already sent a more lengthy email yesterday that will hopefully be read by all, if not already part of your packet this afternoon. I am very much opposed to installations of artificial turf throughout the Bay Area, and I'm working to educate and convince those voting for this toxic material to choose natural grass. Artificial turf is extremely damaging material affecting our environment and the health and safety of all. I know that much material has already been sent to the County Board of Supervisors as well as to individuals in the County Public Health Department. I am extremely hopeful that enough research is being done by those responsible for the health report that is being prepared for you all and for the County Board of Supervisors on the dangers of artificial turf, specifically as it affects the health of our community. That it will contain all the necessary findings such that it will be clear that a ban of this toxic substance is our best step forward. There are so many new medical findings about the microplastics being found in the human body, which include those shredding off of artificial turf surfaces. We should not be contributing by using expensive, unnecessary plastics. From a health standpoint, it is clear that following the precautionary principle should be enough for this conclusion, even if conclusive evidence is not yet available. If we don't act now, we are risking the health and welfare of all future generations and possible lawsuits as well. Thank you.
And Madam Clerk, was that our last speaker under public comment?
Correct.
It was. Then we'll say thank you, and we will move from item 2 to item 3, which is the consent calendar. Supervisor Lee, the recommended consent calendar is items 11 through 17. And I'm thinking that if you would like a motion to approve the agenda, including the consent calendar as contained in our published agenda, in addition to item number 8, might be timely. Does that work for you, or do you want to hear item number 8?
You spoke my mind. Thank you. So I certainly agree with that and make the same motion for approving the current consent calendar, adding item 8 to consent as well. Thank you.
Thank you. And Supervisor Lee, the reason for moving item number 8 to consent is simply that we have the report. We've been getting this on a regular basis. I'm thinking that perhaps if you were to incorporate it in the motion, we'd get one more report in June and then make it a semi-annual report now that it's been underway for a while.
That's perfect. Thank you.
All right, Madam Clerk. So I think County Council will let us move in this direction. We're going to approve the consent calendar with one change, which is to add item number 8, but coincidentally indicate that the motion and the second includes direction to hear this item yet again in June, and after that semi-annually rather than on a monthly basis. All right? Thank you very much. Motion by Lee, second by Simidian. Do we have any speakers on consent calendar?
I do have 2 hands up to speak online. No speakers in chambers.
All right. Again, this is for items that are on the consent calendar, folks. So for those online, want to welcome you, but also ask if it's not to speak on a consent calendar item, that this is the time to drop your hand, virtual or otherwise. Madam Clerk, go right ahead. Who's our first speaker?
Our first speaker is Michael Rogers. You'll have 2 minutes to speak.
Okay.
Timer will start when you begin speaking.
Hi, thanks for your time today, supervisors. I wanted to talk to an item on the consent calendar, which is the Health Advisory Commission work plan for the following fiscal year. We have items on integrative functional health, on dentistry for the less affluent parts of the county, on telehealth in general, and on childhood onset diabetes and obesity we've been looking at for a couple of years now, as well as lead poisoning. We have for the first time in 4 years, I've been attending meetings since before I was a commissioner. We had a lack of a quorum at our last meeting, and we've had outstanding seats in Districts 4 and Districts 1 for some time. And we'd like to get these filled because we don't like to miss meetings. We like to get stuff done. About half the time you get commissioners that actually do stuff. And in the waiting lines and applications that are in District 4, we have a person who's done consulting work with our committees without being a commissioner. We'd love to have her on board. But that's all I have to say today. And thanks for your time and attention. Looking at the work plan.
Thank you. And our second speaker is?
We did have a hand up from Ken Horowitz, which has since gone down.
Okay. Any other speakers on item number 3?
That concludes public comment.
All right. Then please call the roll.
Vice Chairperson Lee,
Aye.
Chairperson Simitian.
Aye. Motion carries unanimously. Thank you very much. That takes us to item number 4, which is medical staff and allied health professionals privileges as enumerated in 4A, 4B, and 4C, D, and E. And who is here to present on this item?
Dr. Morrison is online.
Okay. Let's go to the
Thank you,
online.
Supervisor Simitian and Supervisor Lee. Dr. Harry Morrison, the Enterprise President of Medical Staff, and I'm here to present the Enterprise Medical Executive Committee report. We have 3 privilege sets and 2 forms submitted for approval. The privilege sets for neurology were to add additional non-core privileges for procedures done by neurologists, and the privilege set revision for the physicians in pediatrics was revision to the safe exam privileges. The 2 forms that are submitted for approval are for the corrective FPPE documentation.
Thank you very much. Let me turn to the clerk, see if we have any speakers on this item.
We do not.
We do not. Can I get a motion, Supervisor Lee?
So moved.
Supervisor Lee moves approval of item 4, A, B, C, D, and E. I will second. In the absence of any speakers, please call the roll.
Vice Chairperson Lee,
Aye.
Chairperson Simitian.
Aye. Motion carries unanimously. Thank you all very much. Thank you, Doctor.
Thank you.
Go forth and heal. That is item number 4, so we're on to item number 5. This is our report from the public health officers relating to COVID-19. Dr. Rudman, what would you like to share with us today?
Thank you so much, Mr. Chair, Mr. Vice Chair. So 2 items I want to highlight for everyone today. The first is our usual COVID status update, and the second is a little bit of extra information about H5N1, a subtype of flu that we're keeping a close eye on. So monitoring the wastewater today, I will note that we are seeing a bump not only in the Palo Alto sewer shed, but actually as of today, since this was published on Friday, we have seen also the San Jose sewer shed cross that threshold into the high level. Now, this is nowhere near what we saw in our winter surge, nor is it appearing to significantly impact any of our healthcare settings right now. But it is something we're keeping a close eye on and want folks, especially those who are medically vulnerable, to be aware of, and can certainly update themselves and their organizations by checking the wastewater on our website. Second, I'll note that the RSV season does appear to have abated and ended as we normally see and hope to see at the end of the winter, with near 0 levels in all of our wastewater sheds. But then finally, influenza, and this is specifically influenza A here, we've been tracking. I believe the thoughtful supervisors asked questions about those bumps we were seeing in Gilroy in our last month's report, and you'll see that there's been another sort of up and down bump in that region again with respect to flu A. And part of the reason this matters right now is because the H5N1 bird flu, which is what we call a highly pathogenic avian influenza, a type of flu that we know is impacting wild birds and some domestic poultry all over the country, is now newly being detected in other parts of the country among cattle, especially dairy cattle, and in 2 rare cases, dairy cattle workers, humans who were working directly with dairy cattle. And so when we saw this spike, knowing that that's happening nationally and that that flu is a type of flu A, we launched into high gear to make sure that this was not an indication of H5N1 in Gilroy. And fortunately, I want to share what we did to leave us with the finding that we think this bump is not due to this unusual bird flu in Gilroy, but all the things we're doing to make sure it stays that way. So again, H5N1 is a disease we know makes birds incredibly sick and has, in theory, the ability to make humans sick, although the examples we've seen so far are mostly very mild illnesses in direct dairy workers. And to date, there has not been any finding of cattle or humans anywhere in California, including here in Santa Clara County. But because we know most of the agricultural work in our county happens in the southern part of the county where our Gilroy sewer shed overlaps, we did a couple of extra steps to make sure we don't need an additional layer of attention there. First, we worked with our partners at Stanford to test those wastewater levels specifically for the H5 subtype, and it came back negative. No H5 was found, even on the days where we had the highest levels of type A flu in South County. Second, we launched a full collaboration with our agricultural commissioner and the State Department of Agriculture to understand both how the overall dairy practices in our county are going. Are they seeing sick cows? Are they seeing sick workers? And understand where their waste is disposed of. All of that information was likewise reassuring that we are not seeing signals of sick dairy cattle or dairy workers in Santa Clara County. And then finally, we used additional typical surveillance systems we use for keeping an eye on diseases of concern like flu, where we looked at overall visits to emergency departments in South County and overall reports of human flu testing. And all of those showed that, yes, we're probably seeing a late flu season in Gilroy, but not one that appears to be H5N1 or is otherwise concerning. So all of these were reassuring, but that said, we don't rest there. What we do as a public health department and make sure it stays that way. So we're continuing to work with our state partners, our local ag commissioner, our local dairy operations, local veterinary experts to make sure we have an eye on this topic, and should anything change, including other detections elsewhere in California of cattle or human infection, to consider what other activities we would ramp up. And that's my update for you today. Happy to take any questions.
Thank you very much. Let me see if we have any speakers on this topic.
I have one hand on Zoom.
Let's go ahead and take that one speaker and then have comments and questions from the committee members. Go right ahead.
Our first speaker on Zoom is Michael Rogers. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Thanks again for your time. I just had one quick question. Fascinating report. In the county wastewater analysis of influenza, do you normally look at subtypes in that case? Thinking back to different influenzas that we had that were very strong in recent years, notably influenza A Victoria in early fall 2019 had very high severity and mortality rates with pediatrics, for example. I'm just curious whether you normally split out the work that's done in the wastewater for other types of influenza and other microbes. Thank you.
Thank you. And while we don't typically accommodate Q&A during public comment, Dr. Redmond, I will ask a general question if you have any thoughts you want to share when it's my time to weigh in with comments and questions. But first, let me turn to Supervisor Lee, see if he's got comments or questions, and then I'll have a couple.
Thank you very much, Dr. Redmond, as always. Very informative and somewhat interesting to see where this H5N1 bird flu is going. So for a while, this has been a flu that affects birds and cows, but now there actually are cases of the transmission jumping into humans. So certainly that's not exactly good news. But so far, it seems like the impact is not in California yet. Is that what you're seeing?
That's our best understanding right now with these multi-layer tools we have that are excellent but not perfect. And certainly we do know that there is bird activity in California. And so there is a very real concern that we will start to see cattle infections in California. So I see our job here in Santa Clara County to both protect the cattle and dairy industry and work with partners to do that, but then make sure that anyone who works closely with birds or cattle, who are the group we consider, the humans we consider to be at risk right now, also have added layers of protection, like access to protective equipment, testing, and what kinds of warning signs to look out for in terms of illness.
So if that's the case, should we, like, for example, we sometimes see dead birds in the streets and whatnot. We should definitely take extra caution when handling anything like that.
Absolutely. Any kind of interaction with dead animal, we certainly urge people to work with either their local animal control or vector control, depending on the animal type, and that varies by city or portion of the county. But all of that, we coordinate closely with those animal control and vector control partners to perform appropriate testing depending on the kind of animal and help keep people safe if we do understand there could have been an exposure.
Thank you. On the earlier slide, when you showed that was a flyer or a poster of some sort of a PSA of talking about how we need to avoid drinking raw milk or raw milk made product, I guess cheese, yogurt, and the like, right? So I just want to double check with you. Besides that, is it time for us to no longer have rare or medium rare and when you order our steaks?
So it has been wonderful to see how quickly our local public health department can collaborate with state and federal partners to learn more about meat and food safety. And fortunately, our own environmental health department is expert in this area. So what we've learned lately is cooking meat works. And nationally, we are so far not seeing H5N1 in cattle raised for meat. In addition, we know that pasteurization works. And so while nationally, outside of California, where there have been dairy herds impacted, while the virus has been found in milk before pasteurization, after pasteurizing it, we only find dead virus that we think cannot make someone sick. So pasteurized milk and cooked meat, to regular recommendations for cooking mostly the outside of the meat, are effective in killing any kind of these infections that we worry about. However, we don't know if we can say the same thing for raw milk, and we also know that raw milk products carry risks of other diseases that we do routinely see in Santa Clara County. So that's why our recommendation to stick with pasteurized products wherever folks can.
Thank you. Then there is currently no such thing as vaccinations regarding the H5N1, correct?
Interestingly, there's vaccination for animals, but there is not a specific vaccine for humans. But there is, we understand, one in the works, just in case. And so we look to our federal partners to give us updates on that. But we understand that the same mechanisms that quickly brought us safe and effective COVID vaccines are working on a rapid H5N1 flu vaccine for humans as well, just in case.
Just in case. Thank you. And since we're talking vaccinations, how about the next flu shots or the our coronavirus type potential shots coming up? Are there be new shots coming up in the fall?
What we know so far is, first, everyone is recommended to be up to date on this past COVID shot and flu shot. And so to some extent, that applies to our dairy workers, our poultry workers as well, that being up to date on even routine flu shots may add a layer of protection, not only against seasonal flu, but any of these unusual forms as well. In terms of what we're hearing for the fall, everything still suggests that late summer, early fall, we'll expect to see an updated COVID shot and an updated flu shot, but I don't have any exact details on when, how those will be accessible, or what variants they will cover at this time.
Great, thank you. And we'll definitely get that by August, probably, when we get back, hopefully.
I am hopeful.
All right. Along the way about vaccines, Mpox, I heard, is now coming back again with some type of strain that's even potentially more serious. So for those who have received the Mpox vaccine before, do they need to have a new vaccine on it, or is this something that they would already have some immunity?
So there are two different phenomenons for these two different types of Mpox that we need to be aware of. One, the clade 2 variety, the one that caused a significant outbreak here at home in Santa Clara County, all over the U.S. and across much of Europe now 2 years ago, is still around. And so we are seeing people, especially those disproportionately men with male sex partners, trans women, and others with multiple sex partners or with past STIs, sexually transmitted infections, are recommended to be up to date on Mpox vaccination. They do not need to get revaccinated if they've had the full series, and that is 2 shots a month apart. So anyone with sexual risk factor for that version of Mpox that's circulating here, if they've had 2 shots, they are not recommended to receive further vaccines. If they only ever got 1 or they were not vaccinated, they should go ahead and seek vaccination for that added layer of protection. In addition, There is another clade of Mpox circulating in other countries that seems to be more severe, but less transmissible. We have not yet seen that here in Santa Clara County or anywhere else in the U.S. It's something we're monitoring for. We used wastewater to monitor for Mpox, among other tools, but fortunately not something we've seen here. But should that change, we would revisit our vaccine recommendations at that time.
Previously, we have a shortage of the Mpox vaccine, so there was very specific guidelines of only pregnant mothers and individuals who have these issues are eligible to get the vaccines. Now that I don't think we have that type of shortage right now, would this be a good time to do some PSA to recommend more people to get this vaccine if they are afraid of it?
Absolutely. So the supply is adequate, and there are no longer restrictions on who can be vaccinated. If you feel you are at risk based on descriptions of understanding that it's mostly folks who have sexual contact who are at risk, or other sort of close intimate contact who seem to be getting Mpox, then there should be readily available vaccination. Part of the concern, however, is that the free supply is now limited. So the county and state receive, or we in the county receive free supply via the state in a program that we understand to be ending in August. We do still have adequate supply we think will enable us to offer free vaccination to anyone seeking access via the public health immunization clinic or any outreach that we're able to do to provide Mpox vaccination. But it may mean that others outside of seeking care through the county will need to either be insured or pay out of pocket for the vaccine, especially as those previous supplies of free vaccine dry up.
It's almost like if you want your vaccine, get it before August to get it for free.
Yes, we're certainly recommending folks get it. We also know that certainly our hardest time being hit with Mpox was 2 years ago over the summer, but last summer we did see again a small bump in how many folks were getting Mpox, we think related to travel, meeting new partners, and just sort of seasonal increase in the kinds of activities that we know can spread Mpox. And so it is a good time for folks who may be at risk and who have not been vaccinated or not fully vaccinated, didn't receive their second shot, to go ahead and get it now. And they can do that by going to the public health website, where there are links to several pharmacies that offer it, including the public health immunization pharmacy.
Great. Thank you very much, Dr. Redmond. That's all the question I have, Chair. Thank you very much.
Thank you.
Thank you. Dr. Redmond, you looked like you were leaning in when we had some inquiries from a member of the public earlier. You want to share your thoughts on that topic?
I do, thank you, and I'm very appreciative that we have such a knowledgeable public who have followed the development and use of wastewater as an important surveillance tool for up-and-coming diseases. The answer to that community member's question is no, for the most part. We are not specifically looking for various subtypes. It is really more of an emerging field, a investigative or research or academic endeavor to go look for a specific subtype. And it was the concern about H5N1 spreading in new and concerning ways that prompted us to work with our academic partner to look specifically for H5 in this case. Had we not done that, had they not taken the lead, had we not coordinated with them, we may not have that information, which we now have on a national and ongoing level. So these types of changes in how we used wastewater need to happen in real time. Every season, every month practically, we evaluate what diseases are circulating, which ones we're most concerned about, and what are our resources for wastewater testing, and reconsider what is the best use of them. And that may be sunsetting some of the winter season viruses we look for to focus on things that spread more during the summer, or target specific subtypes upon a general concern. But there's a lot we don't know about what's in the wastewater, including, for example, are there other subtypes circulating? We haven't looked to that degree in Flu A in Santa Clara County.
Thank you. Let me take us back to the COVID conversation. Some of us have been reading in the newspaper about FLIRT. What can you tell us about that? This is an acronym for an emerging COVID virus, as I understand it.
My understanding is we're not seeing changes in the variants that are circulating here in Santa Clara County, even with the rising levels we've noticed just in the last few weeks. And I think my best understanding is there's still more to learn than there is known, but I can get back to you with more information.
Why don't we ask you for that at our next meeting in June before the summer recess?
Excellent.
Which allows me to segue easily to my next question, which is, a lot of folks will be traveling during the summer, so, you know, good news is folks will be outdoors. Bad news is a lot of folks will be traveling and in confined spaces as they travel or when they get to destinations. Thoughts about precautions, appropriate approaches to summer travel?
Thank you for that question. I think with respect specifically to COVID, we'd advise folks to look where available at wastewater levels, and in some cases, the CDC will have specific travel advisory pages for countries outside the U.S. To understand, are there threats that need to be considered, malaria, typhoid, are there other specific diseases to worry about in a given area someone's traveling to? There are very few places that have the level of consistent wastewater monitoring that we have here in Santa Clara County, but many jurisdictions will post their wastewater findings so that folks can gauge their own level of risk and plan accordingly. And then in general, for places like airports, bus stations, hubs where many folks coming from all over come together, especially indoors, are some of the highest risk places for all kinds of exposures over these even outdoor summer months. So those are places where I encourage folks to take additional levels of precaution, such as wearing a mask.
My ears picked up when you mentioned that there was just, the discussion, anticipation around a new COVID vaccine late summer, early fall, and I understand that's potentially helpful for the winter months, which are particularly challenging, but of course for all those folks who are traveling during the summer, a day late and a dollar short, no disrespect to folks who are in the industry, but what does that mean? Folks, my recollection is that we had what was initially called a booster, and then we were told, no, it's not actually a booster. It's sort of part of an emerging regimen of more or less annual shots, and that there was something after the booster people were supposed to get. Can you just sort of bring us back up to date, or at least me back up to date on where we stand on all that?
Right. I think our terminology keeps evolving, but there are sort of two general principles we're paying attention to. One is the last vaccine you got a good match for what's circulating right now? And that's part of why the FDA continues to seem to plan ahead for creating a new COVID vaccine every year so that they can look at what are the latest variants, match those variants to the vaccine, just as we've done for flu for years, if not decades, and get that best updated one out to folks. In addition, there's recognition that people of different ages and different immune status wane in their immunity from those shots with different periods of time. And specifically, older adults and people with compromised immune systems, their level of immunity might wane, might decrease faster than others. And so there is an updated recommendation that anyone who is 65 years and older should receive a second shot of the one most of us got last fall. So if it had been more than 4 months since they got a vaccine last fall or winter, a second shot can re-up them through the summer. In addition, anyone who has an altered immune system, who takes immune suppressing medication such as cancer treatment, or who has diseases that impact their immune system, is also recommended to get a second shot of the version we all got last fall or early winter, and that can be as early as 2 months after your last shot. So there is a layer of protection for our most vulnerable folks that keeps you buffered through the summer before that next one comes at the end of the summer or early fall.
And for people who didn't get that second shot, who didn't get the first shot, which of course means that should they get what you're calling the second shot?
Yep, go get it right now.
Okay.
Yes.
All right, if they're in that category,
Yes.
obviously. One moment, please. I think those are all my questions. Thank you very much.
Thank you.
And we'll look for the report back on FLIRT at our next meeting. Thank you. Then That takes us to item number 6, report from the Office of Supportive Housing about the
Pardon me?
implementation.
Are we going to vote on item?
Forgive me. We should do a quick motion. Supervisor Lee to receive the report on item number 5. Thank you for the reminder.
So moved.
Motion by Lee, second by Semidian. We have had public comment. All those in favor, please say aye. Aye. Any opposed? Hearing none. Motion carries unanimously. The record is now good. Thank you again, sir. Item number 6, we're going to hear from Ash on long-term services and supports in our housing pilot program. Let's ask staff to introduce themselves loud and clear.
Good afternoon, KJ Kaminsky, Deputy Director with the Office of Supportive Housing. Here I have a few slides to share an overview of the Long-Term Services and Supports, or LTSS, housing program pilot, and the lessons that we've learned in the first 6 months of implementation.
Thank you very much. Go to it.
So we, as you may recall, in late 2020 received a referral from the board to work with the managed care partners and the LTSS integration committee to develop supportive housing options for individuals leaving skilled nursing facilities by pairing health plan funded services at site-based PSH units. We worked with the LTSS integration committee to come up with the program procedures, determine the eligibility and the process by which this program would operate. And in the summer of 2023, launched the pilot program, finalizing those eligibility criteria and procedures, and identified Kiefer Senior Apartments as the location for the initial units for the pilot. At that point, assessments and referrals for the program began. In November of 2023, we entered into agreements with Anthem and Santa Clara Family Health Plan to fund the services for the permanent supportive housing residents that were paired with the subsidies at Kiefer Senior Apartments. And in March of this year, Kiefer Senior Apartments opened, and some of the folks referred through this program began to move in. So as a little bit of background, because a lot of the lessons we learned in this process were related to the referrals and eligibility and document gathering. So I'm going to give a brief overview of our standard process as well as the process we developed for this program in particular. Our standard permanent supportive housing referral is housing assessments are conducted by partners across our supportive housing system, basically meeting people where they are. Those individuals who are assessed are added to our community queue, and the referrals are pulled from the community queue based on the unit of it that's available, whether it's for a senior or family or transition age youth. The next person with the highest level of need that matches that population type is referred to the units. Our client engagement team at the Office of Supportive Housing then does the screening and intake process, determines the eligibility, and provides a lot of support for the documentation that's necessary for both eligibility for the program, such as verification of disability, identification, also supports them through the process of applying for the property itself, as well as through the Housing Authority application process. So that's all conducted by our OSH client engagement team. And then the clients are referred to the properties based on their household size and assisted with that move-in at lease-up. The referral workflow that we developed in partnership with the LTSS Integration Committee and the managed care partners was that enhanced care management providers, as well as the skilled nursing facility staff and other medical providers, would refer potential program participants, those individuals who were residing at skilled nursing facilities, were unhoused when they came in or didn't have a housing option identified for when they were going to be discharged. They would refer those potential participants to the managed care partners, who would then screen for eligibility. They would conduct that housing assessment, the VI SPDAT, identify those that were scoring in the permanent supportive housing or identified as needing permanent supportive housing, and confirm through an independent living assessment and their clinical readiness to discharge that they were ready to be referred to permanent housing, as well as ensuring that they were meeting other eligibility criteria such as 55 or older. They would then refer the eligible members to the Office of Supportive Housing. That documentation process then begins, and our client engagement team would confirm the eligibility requirements for the subsidy program, while the managed care partners would coordinate with the care teams for the facilities where the residents were located to secure the necessary documentation. And then finally, in this planned process, the care teams would work with the skilled nursing facilities to coordinate discharge, identify in-home supportive services service provider as needed, and OSH staff would coordinate between the property management and the subsidy provider to ensure a smooth move-in. As we began to implement the program, we did identify some challenges that are outlined in the report, and I just want to highlight a few here. And we'll note that we're regularly meeting with the managed care partners to identify ways that we can address the challenges that we've seen. The first is just challenges with referrals. We found that due to the large number of units that we were trying to lease up at one time, I think 40 plus units at Kiefer, we needed a lot more referrals than we were receiving. And as you know, permanent supportive housing is a precious resource, and we don't want to leave units vacant because we have hundreds of other folks waiting for permanent supportive housing. We also found that in addition to not having enough referrals in the time that was necessary to lease up all the units at Kiefer, many of the potential participants were unable to live independently, and some were already housed. So we did end up identifying 6 members, as the report said, and I think 5 ended up moving into Kiefer, who were in need of permanent supportive housing, were good fits for the program, and successfully moved in. But there were also we had initially received 46 referrals, so approximately 40 of those referrals were deemed not able to live independently, were already housed, or didn't meet other eligibility criteria. Lastly, the last challenge that we identified was many of the members or the residents didn't have the necessary documents, and it required a lot of our client engagement team at the Office of Supportive Housing, a lot of our time. We had to eventually dedicate a full-time rehabilitation counselor to go out, meet with the residents. Many of them couldn't go get ID, so we were supporting them through that process. Challenges with meeting with the property, so supporting them through that process. It was labor intensive, and so to move forward, that additional support would be needed because we had to pull staff off of their regular duties in order to support this program. I think we have learned a lot and see opportunities to improve, and have been meeting with Anthem and Santa Clara Family Health Plan to implement some changes, including additional training for partners. The managed care partners have identified staff to support both the screening and document collection. That would be point people and sort of experts in this program that would be better, would be able to gain more knowledge of the complex process and housing authority application, documents needed, the property lease-up process, so that there could be a smoother transition into the permanent housing, and regular ongoing meetings with the MCPs to assess how it's going along the way. We see opportunities for units at Kiefer as they turn over, as the property that was initially identified, but also looking at other permanent supportive housing units across our system that may be well suited for folks discharging from skilled nursing facilities, that we could refer folks from this program into those other properties as well. And with that, be happy to take any questions.
Thank you. This was an item, as I recall, Supervisor Lee, that had particularly engaged your interest. Why don't I defer to you on this one? Go to it, sir. Questions, comments?
Let's get the public hearing.
Forgive me. Do we have members of the public who wish to speak?
No cards in chambers. Giving it a moment and still no hands in Zoom.
Back to you, Supervisor Lee. Thank you for the courtesy.
Absolutely. Thank you so much, KJ. Great report for what's going on. And it's a very labor-intensive program, given the amount of documentation from various agencies and crossing a T and dotting an I. And it's one of those situations where it's very hard for everybody to pass through. And so with the numbers, I want to double check. You said there were 46 referrals, but ended up with 40 being rejected. Only 6 eligible. Out of all 6, only 5 individuals moved in, correct?
That's correct.
Right, so the numbers is practically only like 10% of those referred actually moved in, so that's a very, very low number. Now, initially on the report, it talks about the intention because of the fact that there are 46 of these apartments at Kiefer. This is in Sunnyvale, correct?
Yes.
Yeah, and so out of the 46, the plan at the time was to refer 138 members, 3 times as many. Are these apartments where you'll be have multiple people staying in an apartment, basically 3 per apartment? Is that the idea?
Could you repeat the question? Sorry.
Sure, because the goal was 138 members for 46 apartments. These are family type apartments, or that just separate people could live in one apartment?
I see. Thank you for the question, Supervisor Lee. No, they are individual apartments for individual residents. We identified a higher number of referrals because we know that we anticipated that some people would not be eligible or would not be ready to move into permanent supportive housing. So we did target a higher number of referrals and didn't receive that many from the beginning. And I apologize, Kiefer's in the city of Santa Clara.
Santa Clara, right?
Yes.
It's Kiefer connects those two, Sunnyvale and Santa Clara as well. I think it's right on the border. If that's the case, are the rest of the apartments being vacant for all this time, or actually they did get filled up by other individuals that qualify for PSH through other programs?
We were able to fill the units with other folks that were awaiting permanent supportive housing.
Right. I mean, that wait list is extremely long. Where are we at right now, roughly? Do you have any ballpark number of how many folks are on that list?
I would have to check the exact number. I know our client engagement team at any given time is generally working with about 1,000 folks
Exactly.
to get them eligibility verified and document ready.
Right. So were we able to get close to 130 folks into this apartments, or it didn't work out because of the fact that these are individual units? If only 5 individuals moved in, so they're actually occupying a unit that could have occupied 3 people. I'm not sure if that's how that works. Or some of these are single units and some of these are family units.
So of the units that were identified for at Kiefer for the LTSS program, the 5 members that moved into 5 individual units, and the remaining 40 units, I think it was 46 in total,
Right.
46 units. So the remaining 41 units were filled with other households, I think predominantly a single adult households.
Oh, I see. So at the end of the day, we're nowhere near the 138 number then.
No, the 138 was the target for referrals,
Okay.
anticipating that we would maybe have a third of the referrals would be approved. What ended up happening is, as you said, about 10% of the referrals instead of a third. But if we had gotten 138 referrals, we may have been able to move more folks in from LTSS. With 46 and the sort of low eligibility rate, that's where we ended up with 5.
I think, KJ, it got me confused. I thought there's that many spaces, but actually we're talking about probably about 40, 50 spaces. That's all we've got anyways. With the 46 apartments, with the all single units, obviously we only could fit 46 people.
Correct.
Right? So that's always so. But those spaces were not wasted, but in the meantime, we're also seeing that there's just not enough people qualifying through this referral service. The need of having skilled nursing facility folks released from the system to be places, of course, of very high need. Given what we've learned here, is the recommendation to not proceed with this program and just kind of wrap this into the normal PSH assignment? Is that what we're doing here today? And if you just explain a little bit more what we're trying to do.
Yeah, we'd like to continue working with the managed care partners. We have the agreements to serve up to 46 of their members to identify whether whether it would serve our folks well to identify units in other places in the permanent supportive housing system. So we do anticipate that there is some turnover at all of our permanent supportive housing developments. So there will be some turnover at Kiefer, and as those units turn over, if we have members identified that are ready to leave the skilled nursing facilities, they could move into Kiefer. But we're also looking at other senior developments, other units that we have across the permanent supportive housing system that are ADA accessible and meet some of the needs that we may see on those for those folks discharging from skilled nursing facilities. So we're trying to work through what that shift may look like and how we could do it. The timing is really the challenge here, because as units become vacant, we want to fill them as quickly as possible, and we. Having a sort of list of ready folks from skilled nursing facilities will be necessary to fill those quickly. So figuring out that that flow and how we can have some folks that are ready to move in identified so that we can assist them to move into those vacant units as quickly as possible.
Great. So since these are permanent supportive housing, they don't become vacant frequently as expected the way the program works. Am I correct?
Most people remain housed. We have a really high retention rate throughout our permanent supportive housing system, but there is some vacancy as people move on to other apartments, and so we do have a small percentage that becomes vacant, each month, and would look to make referrals into those as quickly as we can.
Okay. There's been some discussion talking about how the current system, because of documentation or the VI the scoring requirements, making it too hard for individuals to be qualified for this program. Is there anything that we may be able to do so that, like, for example, the 46 referral, that there might be ways that we could change the system so more folks could be eligible, or they basically just, look, they can live independently, they're just not eligible, so regardless of how you change the other requirements, these are just not individuals appropriate for this program?
Thank you for the question, Supervisor. I think, the assessment, we didn't find the assessment to be the primary challenge here. I do think that identifying people that are able to live independently in permanent supportive housing unit was a challenge, and part of our work with the managed care partners is refining the process to be able to identify those, and having some experts within their teams to be able to work really closely with our team to better understand that sort of the needs and where people are moving in and what the requirements are. But the other the challenge we have with documentation, as you mentioned, a lot of it are things like the housing authority. These units are paired with housing authority vouchers, as are the vast majority of permanent supportive housing units in our system. Those requirements aren't going to change, but that's where our client engagement team has really become experts at helping people navigate that process and reduce those barriers. We can work with the managed care partners to refine that process to support their members as well, understanding that there may be some additional barriers in that, while they're at the skilled nursing facility, they may not be able to go to the DMV to get an ID. So working with them to identify how we can address those specifically is part of what we're doing, and relying on and continuing to work with the MCPs and our client engagement team. I think we can we can work through some of that, but we will need to rely on staff from the MCPs to support that process rather than reassigning existing staff for whom they're working on other projects.
Right, so you're basically saying that while they're in the skilled nursing facility, before the assignments, trying to identify those shortcomings, like getting ID or whatever documentation they need prior, so that those barriers could be worked on before they are ready to move in.
Yes.
Right, okay. I also heard that there's a coordinated entry system redesign process on the way, and that OSH is conducting the pilot study to refine the new housing assessment process as well. So, is that correct?
Yes, that's correct.
Okay, so is it possible to provide us a off-agenda memorandum to outline how your department will ensure that these eligibility criteria for the program can increase through the design process and the type of improvement to the system that would increase the eligible members in the future?
Yes, we could provide an update on the coordinated entry system redesign and specifically how we've been working with the managed care. The managed care partners have been engaged in the coordinated entry redesign process as well. So they are at the table. We recently issued an off agenda about the coordinated entry redesign process. But if there are specific requests to supplement what was already issued, we'd be happy to follow up on that. Is it specific to LTSS housing support?
I think LTSS is part of this, obviously, and as we could see right now, I think the LTSS numbers are so low. So the bigger picture, of course, is to really see how the rest of the PSH program can be even more streamlined moving forward, given that the need is so great, and that what we certainly don't want is to have housing being made available vacant, waiting for a lot of these process to go through and getting the housing vouchers and whatnot because of the myriad of paperwork that needs to be approved. So I just wanted to make sure that everything is as you said, if we could get this process much more streamlined and having folks being able to be placed far sooner in the future, given these changes, I certainly want to learn about those. Does that work, KJ?
Yeah, if you can, apologies. But
maybe I could
just
follow
to
up with you with my
clarify-
staff too. Yeah,
but just to make
my
sure
brother
we
Daniel
can-
will give you more further refinements on these questions, and we'll work something. Yeah, thank you
That
so
would be
much.
great. Thank you.
Thank you so much. That's all the question I have, Chair.
I have no questions or comments, so let me ask if there's a motion to receive the report.
Yes, absolutely. So moved.
Motion by Lee, second by Semidian. Please call the roll. We've already checked on speakers.
Vice Chairperson Lee,
Aye.
Chairperson Semidian.
Aye. Thank you very much. Takes us to item number 7. Mr. Draper, is this you?
Good afternoon,
Or is it Ms.
Supervisor
Solov as
Semidian.
well? Hi, who's joining us?
Doug Koenig, Deputy Director.
Thank you, Mr. Koenig. Let me push the right button on my machine and see if I can see your smiling face here. One moment. There you are, headphones and all. You look like you're ready for takeoff, sir. And
Yeah, that's right.
let me see if Ms. Soloff is joining us today as part of the audit team. Yes, no, maybe? There she is. Ms. Soloff, welcome and thank you. Thank you, Ms. Draper as well. Thank you, Mr. Koenig. And then Ms. Soloff, will the folks from Veneer be joining us, or are they available, or are you going to channel them if there are questions on the audit?
Mr. Price should be with us now.
All right.
I'm available. Can you hear me?
Thank you, Ms. Price. All right. Short version is we have some reports from Facilities and Fleet. We have materials from Ms. Solov representing the quarterly status of the construction with information from Veneer, our construction management and audit team as well. Let me ask you, Ms. Solov first, and then Mr. Koenig, if that's the right order of business here. Are we still on schedule?
We are, well, you're asking Veneer first, or?
I'll ask Ms. Soloff, since the official agenda item today, I believe, is to take a look at the audit as well as the report from the Facilities and Fleets. So let me start with Ms. Soloff. Ms. Soloff, can you and the folks from Veneer indicate that we're still on schedule?
Yes.
All right. Mr. Koenig, Mr. Draper, is that your understanding as well?
It is currently on schedule. I do have some.
A little
some
louder,
information to
please.
share. It's currently on schedule, but the contractor 2 weeks ago submitted a progress schedule that is projecting a 26-day delay in the temporary certificate of occupancy. That's the day in which county could start the staff and stock operations. And they also are projecting a 36-day delay in substantial completion. And that would be the day in which the county could take possession of the facility. The basis for the projection is a changed condition. The changed condition being the lack of primary power available to the facility, and that's there's two factors for that. One is the power feed, the high voltage feed that is supposed to support the BHSC does not exist yet. It is to be installed by the contractor that is expanding the North Utility Loop, and they are behind schedule. The other factor with that is that the alternate source of power, the so-called Circuit 5, is also not readily available. And the reason for that is their investigation determined that currently Sobrano Pavilion was drawing its power off of that circuit. We are evaluating the projected days of delay. And let me just say up front, the delay has not occurred yet. They're projecting this because they don't see that these circuits are going to be available by the first week of September, which is the time they had in their schedule to start testing their electrical equipment that's been installed in the BHSC. But we're evaluating the days, and regardless of where that lands, we do intend to direct the contractor to develop a recovery schedule so that if those delays are actually incurred, that they will still be able to meet the original milestones. And we don't rule out that one or both of the prime power sources will be available in time. But there is that possibility. And this is something Banner don't believe they had. We didn't get it until 2 weeks ago.
Thank you. Ms. Solov, Veneer, any comments or reactions? If yes, yes. If no, that's okay, but just wanted to get your take as well.
Mr. Price?
I was not aware of the current delay, but I was aware that electrical distribution panel boards and switchboards could be a potential delay.
Okay. All right, thank you. Mr. Williams, don't mean to put you on the spot, James, but I just would be interested in your take, and of course, much of what I'm about to describe took place many, many years before your role as CEO, but you know, I want to start with you and then go to anybody else in the group. It struck me as I was talking to folks in my office earlier today, this is undeniably a large and complex project, and it's an expensive project. That being said, I first proposed this project in January of 2015, and that means that it will be 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 11 years from the date I said, hey, this looks to me like something we ought to be doing, till the date it opens if we stay on our current schedule. And, there were some specific circumstances along the way, but, the irony on this one is at no point did anyone raise an objection, at least not within my hearing. The county staff was supportive, the public was supportive, the board voted 5-0 on more than one occasion. And so here we are with something that everybody agreed was important, everybody supported, and it took 11 years from, hey, let's get this going, to the date that we think it might open, which is obviously not a timeline that, we can be enthused about. So, Mr. Williams, just sort of going forward, what are your thoughts? Is this sort of what we're going to have to expect, in the coming years, or do you have thoughts about how we can avoid that kind of timeline on something like this?
Well, I certainly hope that's not the situation going forward. But let me share some good news, Supervisor, which is you'll see in the packet some photos that show that the exterior building of the site is physically up. And the reason that's good news is obviously, notwithstanding, the time that it's taken to get there, I think that provides assurance, and I will provide assurance, that it means that the building will get completed and it will be opened. And I think that the long road to get here has certainly been long, but that is good news. It's visible and tangible good news. And, we definitely, as an organization, need to address our capacity to manage large capital projects given the extraordinary capital needs that we have. And we've talked about many of those needs at FGOC for the last several months. We have about a $4.4 billion backlog of critical capital needs. And so that is work that administration is undertaking in kind of the planning process and thinking through financing and thinking through timelines and thinking through capacity. But for this specific project, where we are today for this specific project, we have a building that's up, and we will keep pushing to minimize any additional slippage. This is an anticipated additional delay, as I understand what was shared just now at the committee, but it will open and it will be finished.
Yeah, I really do want to ask the team, by which I mean facilities and fleet, and certainly the county executive's office, to think about this larger set of issues beyond this particular project. I mean, the project is long since well and truly underway. The progress is being made. I'll keep nudging until the day I'm out the door to make sure that we're making as much progress in as timely a fashion as we possibly can. That being said, I was struck, as I said, by the conversation with the folks in my office about the length of time this has taken. And to your point, Mr. Williams, if I think I heard you right, $4 billion plus in capital needs, I just want to say it bluntly, everything can't take 11 years. There are cost implications to that. There are service impacts in terms of our ability to meet the existing needs of county residents. Mr. Draper knows, because he and I are in conversation about a lot of different projects, that this is a concern I have that ranges across not just health and hospital projects, but other projects as well. So I do think our county needs to be thinking, all right, what does it take? I'll give 2 examples just by way of illustration, because I sort of want the organization to keep thinking about these issues and hopefully wrestle them to the ground one day. The first is, when we had agreement at the highest levels of the county, by which I mean the head of behavioral health and the county executive at the time, that this was worthy, we had to do an RFP, a request for proposals, and candidly, that process seemed ill-fated from day one, because this was a project that required a little more creativity, little more collaboration, some partnerships, and it didn't lend itself well to the RFP process. So we lost easily a year and a half to 2 years, I think, in what I would now, benefit of hindsight, say was mostly going through the motions. You know, we felt we needed to be the good government organization that we are and respect the process and follow the rules, but all to no avail. And then ultimately, and you know, I would say to his credit, the previous CEO said, you know, we pulled people together in the room from a number of our potential partners. Everybody said, yeah, we definitely need this, but we can't take the lead. And, you know, the former CEO, to his credit, said, all right, then we have to take the lead, and we'll work with our health and hospital system to find a place on the campus, and we'll get it going. But that was, as I say, that was yet another year on top of the year and a half that we lost going through the RFP process. So, you know, literally 2.5 years when kids who were suicidal in this county didn't have the benefit of this option because we were processing it. So how can we make sure we don't keep, you know, running through that drill without a good result and without a benefit to folks we're trying to serve, and in fact with some potentially very costly lost opportunities. Then the other was we had a prior contractor, and that relationship didn't work out. And I don't need to revisit that, but it wasn't the first time, and I worry that it won't be the last, that we struggle to manage a large, complex project like that. So far, knock wood, you know, the current contractor seems to be delivering on time and on schedule, or, you know, on time and, as I say, consistent with the schedule. And if we've got $4 billion and change coming our way, that's an area that's going to require some attention as well. So, Mr. Williams, if you have anything else to say, I would be pleased to hear it, but mostly I just sort of wanted to register my hope that these are areas where the county will stay on it and see if we can't find a way not to process things excessively and without result, and where we can up our game in terms of managing contracting with and the folks, and then managing big ticket complex projects.
Yeah, I would just say, you know, these are issues that are very much on administration's radar, especially in terms of identifying some of the really serious critical facility needs we have. You know, we've had, to your point, this project is, you know, taken quite a long time. We've got some other really critical ones that haven't even gotten off the ground, notwithstanding conversations that have happened for more than 11 years. I'm thinking about one very particular challenge, which is our correctional facilities. And, you know, there's many, many others. And so each piece of this pipeline, whether it's our capacity to timely and effectively supervise public works construction once a project has been let, whether it's the time to actually get an award done, whether it's the bidding process itself, or even the planning process or the financing elements. Each of these becomes a stacking consideration. And then when you're talking about health facilities, we of course have some external confounding factors like the state. So, you know, it's something where I think there's a lot of individual levers to push on to try to tighten things up, and you know, that's a work in process.
Thank you. I was wondering if we could get through the conversation without the word jail being mentioned, and I've now demonstrated that we can't. And I think the distinction I wanted to draw, and I know you know this, Mr. Williams, but I just want to highlight it, is, you know, with the jail, there have been differences of opinion, you know, different approaches. You know, the part of the reason I wanted to highlight this project is I've never heard anyone say don't build it, or I don't think that's something we need to do. You know, as I say, part of what was so frustrating to me, and the reason I thought it was noteworthy for today's conversation, rather than simply accept the report and say, glad we're more or less on schedule, is if it takes 11 years when it's something where we're all on the same page, my God, to your point, you know, a correctional facility where there is a range of views and values, frankly, boy, we're in a world of hurt. So I look forward to you and the rest of the team wrestling this to the ground at some point in the future. Supervisor Lee, I see your light's on. I am done with my questions and comments. Thank you.
Thank you, Chair. Looking at this report, one of the things that caught my eyes is regarding the price. So a really good news is that the final guarantee maximum price being $423,775,000 and change, right? And that we're going to have a decrease of $141,639, which is less than the original not to exceed contract amount. That's the good news. I guess the question is, I can't imagine we are that good of estimating how much it costs to do something that accurately. And I hate to see the final price to be basically gamed to be near the maximum price, because when you look at the decrease, this is not 3 or 0.3, it's like 0.033% discount of what the maximum price is. So my question here is there any way we could go back and look at some of the numbers of how much this thing is costing along the way, that we might be able to find further savings on this? Because let's be honest, I mean, a lot of times we save here, save there. Saving 1% is not that unreasonable. But when you save 1% on this project, we're talking about $4 million. So I just want to raise that as a question, and maybe if Ms. Soloff, I don't know if your side takes care of that side of audit, of finding potential savings in the future. If you could educate me on the process, I really appreciate it. Thank you.
I'm not, I haven't thought about this, and I'm not exactly sure how we would approach it, but I'm assuming that there is enough material and records that we could identify, you know, where the expenses were planned and where they are in some detail.
I think to the earlier conversation, the unfortunate reality on a lot of these projects is that usually this is going the opposite direction. So the fact that right now we're coming with a project that at this point anyway is within the current maximum price is a positive development in the county's history of public works projects. I'm not saying that's where we want to be. I'm just reflecting on the last decade of projects. So I view this as a step towards where we'd like to be.
Oh, thank you, James. I certainly agreed on the big picture, which is this is coming in below estimate, which is wonderful. Don't get me wrong on this one. I'm just thinking that given the fact that there's ongoing charges and whatnot, if we could be able to find ways to potentially find additional savings, I don't think we should just overlook it just because of within budget. That's what I'm saying. Yeah.
No, certainly not.
Thank you.
All right. Thank you all. Can we get a motion to receive the report?
Absolutely. So moved.
And I'll second. Do we have speakers on this item? Have we checked?
I see no cards in chambers, and after a pause, still no hands in Zoom.
All right, let's call the rolls.
Vice Chairperson Lee?
Aye.
Chairperson Simidian?
Aye. I will say motion carries unanimously and Godspeed. Okay. That would take us to item number 8, I believe, but that item is on consent, Madam Clerk, yes?
It is indeed.
Which takes us to item number 9, which is the North County Clinic. So we're going to let Mr. Draper get his exercise and walk back down to the chair here. And this is simply, again, to receive report on a project underway. In this case, the New Valley Health Center in North County. How are we doing? I see the pictures.
Actually, we're making really good progress, Supervisor. I'll leave it at that, really. I think we're going to be getting you a clinic open somewhere between middle of September and middle of October, and I'm hopeful it's close to the first date.
I understand there was some back and forth with the property owner of late because, as I understand it, in this project, some of the improvements are within the purview of the property owner, and for the tenant improvements, are those on schedule, on time?
Yes, sir, they are. The whole project is actually the landlord's architect and design and construction team.
All right, and my recollection is we recently looked at some additional funding, yes?
There's a little bit of a question about the need for additional funding. However, we have a $22 million project budget, and currently the project is estimated to come in around 21.4. We'll keep an eye on it. It's close.
Okay. All right. I don't think I have any other questions today. Supervisor Lee, any questions before I check to see if we have any speakers?
No, thank you.
All right. Let me check with the clerk. Do we have any speakers on this item?
We have no cards in chambers, no hands going up on Zoom.
Then I'll ask for a motion from Supervisor Lee to receive the report.
I just have one question for Jeff, if I may, Chair.
Please.
We are now, the initial certificate of occupancy was issued or intended to be sometime in July. Now it's looking like in beginning of August. Just want to say, and it's predicted that it would finally happen by mid-September to mid-October for licensing to be completed, so that it would be done by the October-November 2024 timeframe. Is this a pretty solid date, given how close we are, and that you could even schedule the ribbon cutting by now?
Can we schedule the ribbon cutting? I would hold off on that just a little bit longer. Not much longer, though.
Yes, thank you. I just want to make sure that it is happening, and this is something I certainly want to have happened when our esteemed chair here is still on the Board of Supervisors to be leading that ribbon cutting. Thank you.
Clearly our hope. That's what we would like as well.
Thank you.
Well, thank you all, and just for the record, no one is proposing an extension on term limits, so that people don't get worried about that. I think we now have a motion from Supervisor Lee to receive the report. Second by Semidian. Please call the roll.
Vice Chairperson Lee?
Aye.
Chairperson Semidian?
Aye. All right, the motion carries unanimously. That takes us to item number 10, which is I call it our omnibus item. And we have first 10A, but we run all the way through 10G. Do we have any speakers today for item 10?
No speakers in chambers, and no hands going up in Zoom.
All right, then we're going to say no speakers. We're going to go through the reports, and if a member of the committee has a question or a comment, we can lean in along the way or wait until the end. So let's start with 10A, receive the report from the Chief Executive Officer. Mr. Lorenz, anything you'd like to share with us today?
Thank you, Chair Semidian. Good afternoon. I just have just one item I just wanted to share with you that, as you well know, the state budget has had some implications on the 24-25 budget, and we are evaluating those impacts. At present, most of the items you're aware of, such as the MCO tax, and also the administration is looking to impose an administrative fee on our supplemental funding, both of which we're going to be working with the county exec's office and OBA to determine the extent of those adjustments.
Thank you very much. And then 10B, Public Health Officer. We did cover more than COVID. You did cover more than COVID, Doctor, but anything else you'd like to offer at this point, or are we good?
Just one comment akin to Mr. Lorenz, that public health is closely monitoring the governor's budget, the state budget. As of our best estimates, the governor's may revise has implications up to $10 to $12 million to the public health department, much of which is our most flexible funding source, the future of public health, that really backs almost everything I presented earlier. That said, we know things are still in flux. We are hopeful that the legislature will point things in a better direction, and we won't have to grapple with this, what looks about a 6% cut to our budget on top of the $20 million or so we've already had to take this current or in preparation for next year because of federal decreases. So all eyes on the state. That's all. Thank you.
Thank you. Supervisor Lee.
Yeah, just one item, Dr. Redmond. This morning I had a meeting with our experts over the behavioral health, and so Dr. Shao and also Dr. Ho, and we talk a little bit more about the need for more PSA and outreach regarding the type of program, not just for, we've been talking about so much on fentanyl and all that, and sometimes when we speak so much on one issue, we are not talking enough about the other stuff, from meth or even, for that matter, cannabis. Because a lot of times when things are legalized, people somehow feel that it's suddenly a safe items, which is not true. As we know, cannabis, or for that matter, alcohol, is definitely not a safe item. It's legal, but doesn't mean it's something good for you technically. So I'm just trying to talk with the folks, and I think Dr. agree that we certainly need more public health engagement and with providing more PSAs in those areas, making sure that general public knows there are ways to obtain medication, for example, because only, 3% of those that are addicted to alcohol, for example, are using these medications that has been proven for decades being safe. So I just want to make sure that that message gets to you and that you could continue that dialogue to continue to find ways to publicize those issues, to engage more of our county residents to these services that's available from us. Thank you.
Thank you for that. Yeah, I think there are teams both on the public health side, especially focused on tobacco, cannabis, and alcohol policy, as well as communications and primary education to prevent use or decrease the harms of use, as well as on the behavioral health side. I understand there to be their primary prevention team focused on outreach in those areas as well. In terms of your question about methamphetamines, that is something we absolutely have eyes on and have intentions to significantly expand the coordination around not just access to treatment modalities that do exist for methamphetamine, but coordination, harm reduction, and input from key stakeholders on those activities. I would add that all of this work is limited by the resources allocated to it. And so, for example, when the Public Health Department received its Overdose Data to Action grant from the CDC, the original intent was to create several new positions, including a communications role that would focus on this. Because of both the federal decreases in public health funding and the county's budget situation, we did have to instead repurpose those funds behind existing positions and not grow in that way we intended to. So again, something we're keeping a close eye on to try to continue to prioritize public health's role in substance use reduction and harm reduction wherever we can, using the resources we have and trying to preserve the ones we can.
Yeah, instead of just using money to do it, I think there are many ways these days we could publicize things through, I don't know, celebrities and through all the various channels. I think TikTok, for example, or whatnot is being very popular and very, very low cost in terms of getting the message out. So I certainly want to make sure that we don't forget about those channels. Thank you.
Yeah, thank you. Excellent point.
Doctor, it occurred to me as Supervisor Lee was speaking, I did not ask you. I am, for whatever reason, I think it may be the coming season, hearing more, seeing more about shingles. Thoughts there, just because we have you and I can ask you?
Not something on my radar as particularly out of proportion for what we might see. It is, so as you, I'm sure, are aware, it is the resurgence of people who have had varicella or chickenpox in the past when they reach usually older age, but even young adults are susceptible to this. There is a vaccine that does help prevent the reemergence of shingles, and so one of the things we do is to help amplify information about that vaccine and help point people in that direction. But at this point, really the general recommendation is for folks to talk to their doctor about whether they're eligible for the shingles vaccine and utilize normal healthcare delivery systems to access those vaccinations. But if we hear that it is a spike out of proportion to what we might expect, we'll return to this body to share what we're learning.
All right, thank you. Behavioral health, I know Mr. Rao was not feeling top of her game today. Do we have anyone from behavioral health here today?
We do not have a representative today.
We'll revisit these issues then at our next meeting. Valley Health Plan.
Thank you, Chair Simidian. Our report has been submitted, and I'm happy to answer any questions.
Supervisor Lee, any questions?
Not today. Thank you very much.
Then we'll say thank you as well. All right. Then moving along to custody health.
Thank you, Chair Simitian. You have the report in front of you and happy to answer any questions.
Supervisor Lee.
Yes, thank you so much. The questions I have is kind of related to what we spoke with Dr. Redmond regarding the issues of having those programs being made available. And I know we have that with the reentry program. So I guess my question is, while the folks are still in custody, I just want to make sure that those resources are made readily available as well. I think it's really one of the best opportunities to get folks very much focused and concentrated. And first of all, you're not supposed to be able to obtain those substances in custody, in theory. But we all know that that's not the truth, right? There's still those contrabands being smuggled within. So I just want to make sure that those type of resources that we just mentioned about is being made available, whether it's buprenorphine, the shots, the longer shots, supplicate, and how we could make sure that even alcohol type related drugs, if necessary for those who are incarcerated, will be able to obtain.
Thank you for the questions. Definitely all those services are available now. I think we'll see some improvements with the CalAIM that's coming online, where we're going to be able to do a lot more than we currently do on the discharge planning. So I do anticipate many improvements in that space, and of course we'll continue to work with public health as we proceed with CalAIM implementation in October.
Well, the good news, I think, based on CalAIM, one of the changes is to allow those in custody to be able to qualify for Medi-Cal payment for some of these detox treatments while they're in custody. Am I correct?
That's right.
Right. So because of that, we will be able to have a lot more resources to provide that to those who are in custody. So I'm looking forward to that change to take place, and please update this committee when those data is made available, and hope that would really help our residents even before they get into the reentry program. Thank you.
We'll certainly do that. Thank you.
All right, thank you. Do we have anyone from Emergency Medical Services with us today?
Dr. Miller is online.
Ah, great. Dr. Miller, anything to report over and above what we have in the written report?
No, I do have a report, and I'm here to engage any questions.
All right. I have none. Thank you. Supervisor Lee?
None from me. Thank you.
All right. Thank you. You're off the hook, Dr. Miller. And that takes us finally to a report relating to the federal and state health policy and budget landscape. And I see Ms. Carta pulling up her chair. Ms. Carta, what would you like to share with us today?
Good afternoon, supervisors. With me is Angie Melton, who is representing the Margolin Group, and she will be providing a report relating to federal and state health policy and budget.
Thank you very much. Ms. Melton, welcome. What should we know?
Hi, nice to see you all. I wish that I could say things were as busy in DC as they are in California. No, there's a lot going on in California with the legislative session and the May revise and the negotiations around the budget. So that is, top of mind for all of you. In terms of what's happening at the federal level, right now they are kind of wrapping things, working on things in committees with the preparation to push everything to the lame duck session after the election. I know that Bert has spoken with you guys a number of times about how the lame duck session, which starts the week after the election, is really kind of what everyone's aiming for in terms of legislative vehicles. The dish cuts, the delay of the dish cuts has been extended through the end of the calendar year, which means further delay would be included in that lame duck session. The other issues that have come up recently that I believe will probably be included in that massive package during the lame duck would be an extension of the Medicare telehealth flexibilities that started during COVID. They've been extended through, again, the end of the calendar year. The House Ways and Means Committee recently approved a legislation that would further extend those flexibilities for 2 years. I think there's been a lot of talk in Congress about wanting to not do a permanent extension, but instead provide a couple more years for data collection to make sure that there's a cost-benefit analysis on utilizing telehealth in the way that it has been. So again, that legislation will probably be included in this mammoth bill at the end of the year. The House Appropriations Committee has started working on the annual discretionary budget for the year, and they've already said we are going to have a continuing resolution that carries over at current funding levels until after the election. So right now, they're really just focusing on some messaging bills. There was recently a legislation that was considered by the House that believed the formal name was Keep Your Laws Off of My Home Appliances. So they are really doing messaging bills, not getting a lot done right now. And everything is focused on the lame duck session, which is the end of the year.
Ms. Melton, my colleague just sort of made a quizzical look about the Keep Your Hands Off My Appliances law. My recollection is that that's an effort by Republican members of the Congress to push back on the move towards electrification. Am I remembering this correctly?
That is absolutely correct.
All right.
Like, they don't want people to get more efficient appliances. They don't want there to be regulations requiring appliances to become more efficient.
Got it. All right. I have no other comments or questions today. Supervisor Lee, do you want to go down that path?
Well, I would like to share a quick story. About a year and a half ago, I've introduced this thing called induction electric stove cooking. And not understanding what it really means, I actually bought one online, and it was fairly reasonable, approximately less than $100. Plug it in and tried it at home. What really surprised me was, this is no regular electric stove that we are also used to, which takes forever to heat up. Second thing is, I called my little nuclear reactor. When I boil water on that thing, on high, I could get water boiled in 2.5 to 3 minutes. And I tell you, those bubbles are really huge. And what I'm trying to basically say is that electric induction stove is a technology that's available. The cost is coming down significantly. And for those who have never tried it, please try it, because I'm fully convinced. And since the purchase of that appliance, for example, I have a very nice gas stove at home that I love to use for cooking. And guess what? Since that day, that little piece of appliance I bought is now being used for more than half my cooking because of how fast it is. And I've just used that as an example to allay up the fears of many people who will say, oh my God, I'm gonna lose my gas stove, and that's the end of the world. Look, it's not what people think, and I think there's a lot. It's about education, about people understanding how it works, and a lot of this stuff we just mentioned, Ms. Melton, I think is really based on fear and frankly ignorance. So I just want to say that we certainly have a lot of work to do to help outreach, whether it's PSA, to educate the public what this is about, and certainly this is something that I'm very glad to see that the legislation is getting that direction to come up with more efficient appliances. And when you start talking about putting solar panels on a house and batteries and all that coming together, these are the future zero emission goals that we are reaching. And I'm very fortunate that I can afford putting those things in there, and I'm living the zero emission life now in my own house. So just to get 2 cents to whatever this is worth, that this fear is something that we need to help allay and educate the public. Thank you.
Thank you. All right. Thank you, Supervisor Lee, and entirely my fault if anyone who's watching at home thinks they've tuned into the cooking channel as opposed to the Health and Hospital Committee. Anything on state matters that we need to hear as well? No, not today. Ms. Melton, thank you very much. Please give Mr. Margolin our regards as well. And I think if there's no one on line to testify, and there is not, we need a motion from Supervisor Lee to simply receive the reports.
So moved.
I'll second. Call the roll, please.
Vice Chairperson Lee?
Aye.
Chairperson Semidian?
Aye. Motion carries. Other items have been covered under the consent calendar, and that means we now stand in adjournment. Our next regularly scheduled meeting is June 26th at 10 o'clock in these very same chambers. Thank you all very much. Have a good day.